Welcome to the UK Medical Freedom Alliance. We are the most recognised and respected organisation campaigning for your right to informed consent, bodily autonomy and medical choice. We are the voice of ethical medicine.
Hello, everybody, and welcome back to the UKMFA podcast. This is one of our medical ethics reports, and I'm surrounded by brilliant guests today. I'm very, very happy because I am the one here that has no medical knowledge whatsoever and very little knowledge on the subject, but that's probably making me one of the better people to ask the questions that are going to come up. So with me, I have Amanda Hunter, who really, really kindly developed this series of videos about assisted dying and assisted suicide, as it has become known in our circles. I know the government trying to avoid those words, but I think that's exactly what it is. Dr. Liz Evans is here too, because they're our CEO from the UK Medical Freedom Alliance, and she will obviously have some interesting medical questions to ask. But our honoured guest today is Dr. Joel Zivot, who is a practicing academic physician and specialises in anaesthesiology and critical care medicine. A frequent contributor to many media outlets and known as a public scholar with broad expertise, including opposition to the medicalization of punishment in the death penalty. And that's where this kind of all glues together with the terminally ill bill. Now, what they don't mention in the bill are the drugs that they're going to use in order to assist someone to die. The information that we have at the moment is very sketchy. And so we're now going to refer to Dr. Zivot because he has expertise of what's been going on in Canada and how those drugs are being used there. Now, just as an aside, my former profession was as a police officer back in the day, many, many years ago. And so I do like to ask questions, and I want to ask the questions that the normal members of the public would ask. Now, Dr. Zivot has testified before the Senate of Canada over concerns that MAID, medical assistance in dying, has caused. And it's all about the unacknowledged suffering during the death process, during dying. And because the same system is used for the death penalty in the US and for assisted dying in Canada, the research that Dr. Zivot has done has become extremely important because it shows what happens to executed individuals. And the common finding is that they're dying of pulmonary edema. And I know, Dr. Zivot, you've presented your findings to the UK House of Commons, which is very important. I wonder just how much they've actually taken notice of that. But as I say, thank you so much for coming on all the way from Atlanta in Georgia. I know you're Canadian, but you've clearly moved south. Mm-hmm. And I hope you're enjoying the weather down there. So let's get to it, shall we? As someone who is basically, as I described to you earlier offline, the numpty in the room, the one that knows nothing about this really, could you explain to me just what the process is that's undertaken not only in the execution of prisoners on death row in the US, but what also happens to people in Canada when they go through the MAID process?
Sure, I will, Ian, and thank you for having me on and an opportunity to speak with people. I think that we have to kind of unpack your question in a few ways. First of all, the death penalty in the United States, of course, is not a medical treatment, although it is designed to impersonate a medical act. I would suggest that assisted dying is also not a medical treatment and is also intended to impersonate a medical act. And why I say that is, of course, because it would be an unprecedented shift to claim that killing someone is a treatment. Our job as physicians, of course, is not to kill people; it's to try to save their life. Now, let me say also that I'm not a vitalist. I understand that people die. Everyone dies. We will all die. But I see it very clearly that the physician's job is not to expedite or seek the death of their patients. The other thing I would say is that you mentioned the word drug here, which I think is also interesting because, of course, when I speak about, and I'll put this in quotation, a drug that's certainly in capital punishment, and I would argue the same could be said of assisted dying, that this is a chemical. First of all, it is a chemical that in one circumstance is intended to be a drug, and a drug, of course, is medical and for the purposes of healing and helping. But here now, this drug, which is in fact a chemical, is really repurposed as poison. So it's trying to turn this chemical that can either be a drug for healing or a poison for killing.
And can I just ask quickly,
Yeah.
are these synthetic drugs or are they?
These are, it's a variety. Like one of the problems, I think, about trying to figure out, which cocktail, which combination of chemicals would best suit the purposes of killing is that, again, that no pharmaceutical company has a labeled indication on their medication, fit for the purposes of killing. So these drugs are designed generally not to kill you. And so in order to make them kill you, they have to be altered, not pharmacologically, but certainly by dosage. So the main idea here is to try to find, a chemical, a drug, and see how you can make it poisonous. And generally, it's made poisonous by giving, very, very large quantities of it, with the thinking being that, that there's a certain kind of overdose is what you're trying to do. And by doing so, you're causing death. So there is no serious research that can be done or even can be ethically designed, where you could randomize people in a scientific, endeavor, where you could obtain consent, where such a protocol would pass an institutional review board, and then you would answer some questions about, what is the most effective way of killing someone. It's just beyond what traditional ethical medical practice would allow. So what you're talking about here is just kind of making it up a little bit as you go along. And what I would also comment about is, I've had now, of course, a lot of opportunity to talk with other people who are on the other side of this. Although I'll tell you that it's rare that I actually get to have a conversation. Mostly what's happening is that people are debating me, online, but not actually in person, even though I'd be more than happy to speak with anyone in person. It turns out that opportunity is generally not afforded to me. And so I end up in these situations where, what is being said by the other side is, just the manipulation in my mind of language. And there's been very little. And if we were having a medical conversation, I'm sure, as my colleague Dr. Evans could contest, that things in medicine may come forward, and there may be, scholarly debate about whether or not some particular treatment is effective or not, and people would have those conversations calmly and properly. But here, all that seems to be encountered is a kind of, rage or something against, how could I even suggest that what's happening here, should even be subjected to any scrutiny, that the most important principle here is to produce a corpse, and that anyone that blocks the production of a corpse is somehow, of some sort of ill intent. And
it's interesting you mentioned that word rage, because I think this is something that I've experienced when I've even tried to discuss this with friends or relatives. And you get a pushback because I think they find the whole discussion very, very uncomfortable.
It is an uncomfortable discussion, but that doesn't mean that we should not be having it.
No, and I think that what would be useful is to try and explain to them exactly what you've discovered, and that's the drugs that maybe are being used in death row are also being used in MAID.
I mean,
And
yeah, there are a lot of similarities, yes.
yeah, I mean, are they exactly the same, or does the research not really show that?
There's some that are the same and some that are not the same. And I think also that, I mean, I can explain to you exactly what is used and what the idea is if you'd like me to do that now, or
I think so, yes, because
yeah,
I think
yeah.
one of the things that I've come up against is that I've got quite a long contacts in Switzerland, and
Hmm.
they're very open to the whole idea of going to Dignitas or to Exit in order
Hmm.
to end their lives.
Yeah.
So they pay a few hundred, Swiss francs, and then go through a process.
Mm.
But then someone comes to their home and gives them a drink,
Hmm.
which they take, and some pills, and then they die. And I think what they don't understand is what that means, what that dying
Yeah.
means.
I mean, I think that maybe just before we speak about the drugs, we need to understand a little bit about what is, what the action here that is intended. And so the argument, I think, in favor of assisted dying would be something like this. A person's experiences their life as some, version of unremediating suffering, and that they've tried, a variety of other mechanisms to reduce their suffering, and they can see no pathway forward except by ending their life. And the belief, of course, is that death relieves suffering. Now, all that we really can say is that death relieves life, that the only way to know whether or not death relieves suffering is to have survived it, to know that you now have relief. Now, I understand that that's a little, that I'm using language specifically in that way, but I need to push back against the advocates of assisted dying who have taken over the word dignity, for example, even dignitas. It's all about dignity. And so the idea then is if you own that word, it means that anyone that opposes you now is an advocate for the lack of dignity. And this is very problematic. I would suggest that there's something very dignified in someone who is trying to stay alive. And I see no lack of dignity in that. So not only do you have to kind of overcome all this pharmacological mystery, is that you're in some kind of lexical warfare over the meaning of words. And the words here matter a great deal. And if you're saying that you're for the relief of suffering, then if you and you claim that that's what assisted dying is all about, then if you're against it, then you are for the ongoing suffering of people, which again is nonsense.
But the
Um,
organizations that already undertake this are even using uh, parts of the Bible incorrectly, but are using parts of the Bible to
yeah.
justify what they're doing.
Yeah, I think that I'll say belief is evidence free. That once you've decided that this is what you think should be happening here, then, the mind becomes closed. So it's been very challenging, I think, for opponents of this because the advocates have so effectively controlled the narrative by using these kinds of words. And that's been an uphill struggle, I think, to be able to remind people that words like dignity or suffering, have other kinds of important meanings that are not that are not only claimed by advocates of assisted dying. There can be a lot of dignity in trying to stay alive, and
Mm.
also that medical practice is able to address, quite effectively the suffering of people, that they experience as they die.
Please consider donating to the UKMFA. We're really grateful for all donations, no matter how small. Your donations enable us to continue to lobby for your right to informed consent and medical freedom to be upheld, and to provide resources to educate and empower the public. We're the only organisation solely focusing on medical freedom in the UK. So scan the QR code right now that's present on your screen, or go to our website at ukmedfreedom.org, that's ukmedfreedom.org, where you could donate via our donor box system or simply buy us a coffee.
What assisted dying is trying to do is it's trying again to find a combination of chemicals that will cause death. And I would first of all suggest that the success of assisted dying is measured in the production of a corpse, and that there is being alive and there is being dead, and then there is dying, which is the state between being alive and being dead. And the dying part of this, even though it's called assisted dying, is really unclear and even murky. And I think that now there may also be people who might say that their life is so of such great suffering that even if someone was to say to them that in order to get you from alive to dead, you will have to suffer greatly, that our technique of killing you actually will cause you a whole new brand of suffering for a period of time. Some people may say, okay, you know what? I accept the fact that my death will be painful. And I think that there is a lack of, what I see in assisted dying advocates is that their unwillingness to concede that this could be happening. That in fact that the death itself, the dying part, could be highly problematic. And even though there is quite a lot of evidence, both I think in the oral administration of assisted dying, which can go on not quickly, but hours and even days in certain circumstances, and in the intravenous methods of assisted dying, which can have all manner of complications that can be seen, unfortunately, at autopsy. Wow. So sometimes can be, be witnessed, but assisted dying does something quite, I would say, diabolical in its pharmacological choices, and that is that. The way that you actually die with assisted dying in Canada, the actual way that you are dying is that you are given a drug that will paralyze you. It stops you from moving, stops you from breathing. Now, that drug by itself, if one was to be given that drug by themselves, it does not relieve pain, and it does not create any kind of anesthetized state. You would be wide awake and not able to breathe, and you would die of suffocation. So what assisted dying in Canada does in the intravenous form is that they provide two separate medications. The first medication is called midazolam. And this is in the class of drugs known as a benzodiazepine. These are old drugs. At least in the U.S. and Canada, there are drugs called Valium is an old drug, lorazepam or Ativan, alprazolam, Xanax. I'm sorry, I don't know the UK names of these, but
Yeah. We know these drugs.
Okay, so these drugs are commonly used to mitigate anxiety. Now, midazolam, why midazolam became popular as an anesthetic adjunct is because midazolam has a profound impact on memory. And so when midazolam is given at the beginning of an anesthetic, it will block, the recall of subsequent events fairly effectively. Not perfectly, but fairly effectively. Now, of course, that makes sense in an anesthetic where you will survive. But in the case of your death, that whether recalling it, of course, is moot. Mm. And I can tell you that I've given midazolam, to patients before that they are to undergo an anesthetic, and they still may have some anxiety in the moment, but they don't generally recall it. And that's why midazolam is effective. So the claim that midazolam will allay, quote, the anxiety of dying, I'm not even sure that it's necessary at all. Because if you're suggesting, that maybe people who want to die are quite certain of it. And so why they need to have their anxiety relieved, if they're so desperate to die, if that's the practice here, they should require very little relief of anxiety. They should be happy, I suppose, to be facing their death. And so it seems like an odd kind of way to begin on the part of advocates, who exactly is wondering whether they're doing the right thing at all. The drug,
Can I just ask a quick question about midazolam? So does it actually stop the visible manifestations of anxiety? So it makes the people watching think the person isn't anxious, but they may be actually respiratorily depressed and really be suffering, but unable to kind of communicate it.
All of that is true or possible. Like, I don't know. I mean, it's not like if you would be quizzing them, I suppose you could say to them, like, how are you feeling? What's happening here? It's in a way, like, I'll say that assisted dying in this method, and maybe in the UK as well, in Canada, really tries to, in a sense, mimic the way that we euthanize animals. Okay, except that the only difference, of course, is that in animal euthanasia, that veterinarians recognize that the use of a paralytic would be potentially cruel, and they don't do it. But remember that euthanizing an animal, a pet, a beloved pet, really it's intended to also help the person who is watching, the pet owner. So the pet owner may be there with the pet. And so midazolam is used actually in animal euthanasia as a way of trying to make the pet, at least appear outwardly more calm. What the pet's internal monologue is, I cannot know. But you're right that assisted dying is meant to look a certain way for people who are watching, as, by the way, is execution. It's meant to be a witness experience. And so how does it look to witnesses? I've done extensive work in the legal system here in the U.S. about the fact that execution has an outward appearance. And even though, prisoners in the U.S., and I believe there's similar law in the U.K. In fact, the U.S., of course, lifted these laws from the U.K., which is this idea that punishment cannot be cruel. So prisoners have a constitutional right to be punished in an uncruel way. And of course, in the UK or in Canada, that people who are euthanized have no such constitutional right or protection against dying with cruelty. And I have a concern that the paralyzing drug that is given, could result in, on occasion, that there still could be someone who has some kind of sensation, some knowing, that they are now paralyzed. Now, advocates would claim that never happens, that in every instance, the combination of the midazolam and then another drug called propofol creates a kind of anesthetic state of unawareness. And so, and then you may ask, well, what's the purpose of the paralytic? The purpose is that the midazolam and the propofol may not kill you. And so they then have to kill you by paralyzing you. So that's the way you die. It's not that you fall off to some beautiful sleep and then slowly, calmly and without pain die. You die by being paralyzed. And that's how you will die if the technique is injection. Now, in lethal injection in the United States in capital punishment, many states will also use potassium chloride, which they believe will, which is the attempt is to kill you by that method as well. But there are also states that just use the single drug called pentobarbital, which is a drug in the barbiturate class, which is an old drug, used to be a sleeping pill called Seconal. There's some oral barbiturates, but barbiturates, are kind of molecules that might actually kill you on their own right. They have impact on the heart, on the contraction of the heart and other things, so they generally will kill you. But propofol may not kill you, and neither will midazolam. So because those drugs don't kill you, they must finish you off with a paralyzing drug, and that's how you die.
And I have actually witnessed an animal being put down once, and it was instantaneous.
Yes.
But it strikes me that, like, is it very hard to kill a human? Because it feels, and the stories we hear, because I know you've got, Dignity in Dying and all these lobby groups selling the public the idea of this Hollywood death, that they will sit in a chair in their garden, they will drink this like liquid, and they will just fall straight to sleep, and they'll be dead within a few seconds, and it's all very beautiful, and there'll be music playing.
Right.
But the reality that I've read, I mean, with oral stuff, people may be vomiting, they may be choking, they may be, in severe distress. It could take hours, it could take days. And that there's not been an honest conversation about this at all.
I think, that's been the most frustrating for me, is that, like, in medicine, we would never say 100% guarantee. We would just never say that. There's always going to be variation, and we talk about the probability of something. We would never claim. That's why I think that assisted dying, claiming that it is 100% perfect, already sets it apart as a non-medical act. It's a medical impersonation act. And I think that that's very important here. It's trying to represent itself as being, endorsed, if you will, by the best, safest practices of medicine. Even the kind of idea of the word safety is the misuse of that term. Because when we talk about safety in medicine, we're talking about the medicine not killing you. And so what you're talking about is taking the lid off medicine that's designed to be safe and making it fundamentally unsafe, because now the medicine kills you. So I think that, there are a myriad of problems here with these combinations. There is no agreed upon combination because these drugs are not meant to kill you. And so people struggle to find some combination that they think is kind of more outwardly palatable than inwardly, desirous.
Visit our website to get immediate access to our media and presentations, our campaigns, our podcast, our Substack, legal help with support, and our open letters. The address is ukmedfreedom.org. That's ukmedfreedom.org. You can sign up there to receive our newsletter, so you're notified then of our new campaigns, our open letters and calls to action, and any other important updates. Oh, by the way, you can donate there too.
Assisted dying, even though it fumbles along, is very good at producing corpses. And the answer is yes, it's good at producing corpses, and really it's like, what is the deliverable? Well, if you think about this coolly as a business, so what is the product that you are buying? And what you are buying is death, okay? And so how you get there is not part of what is on offer, other than a claim that it's going to be lovely and dignified and so on. But I don't think there's any real evidence or even any real concern about trying to be certain that the way that you die is as billed. And I don't know why there is this fear, and because again, as I've said before, that there are people who would say, I don't care that dying will be terrible. What I'm really seeking here is death. And I'll accept the fact that on the way down, it will be quite bad. Just admit that, admit that.
Yeah, well, they're obviously not admitting that because they're not, it's the ultimate gaslighting, I suppose. That's the common phrase now, isn't it?
Yes.
So you're saying to people, sit on the sofa with your family, and this is something I actually know has happened because I know people that have done this. They sat on the sofa with their mother, the mother said goodbye, took the drink, and then essentially went to, well, they thought died, but she went still. But I guess what you're saying is that, yes, so from the outside, that looks like what's happened. They've gone very, very quiet, and as far as they're concerned, they're now dead. But something else could be going on internally that they know nothing about.
Well, and certainly in the intravenous form of assisted dying in Canada, and before advocates got wind of me or something. I don't know. And I asked, tell me what the paralytic is for. Why are you paralyzing them? And they say it's for dignity, okay? Because movement, that may be observed by witnesses, might be undignified for the person that's dying. So for the sake of the dying person's dignity, we will paralyze them. So outwardly, it will all appear peaceful. Now, when you take an oral preparation, there is no paralytic. Okay, there is no paralytic that can be given in that way. So they just try to use, generally, it's a combination of a barbiturate of some variety, which will kill you if enough of it is ingested. So, but it's going to be variable. Some people will die quickly, some people will die slowly. It depends, of course, on their coexisting medical state, whether their condition will be such that they have a lot of physiologic frailty or instability. And so, how they die, will, and also I feel pretty certain that it's more or less one size fits all. Like, I'm not sure that they're, making doses, they're taking, some kind of history and saying, okay, you've got this condition and that condition, let's modify this in some way. If there are modifications, they're very minor because, again, they're not trying to just kill you. They're trying to really, really kill you. And so they're going to give you very large amounts of things that they, again, believe that more is better and that more will increase the likelihood of killing you. And, that's how it will be designed or how it is designed.
So in the UK, with our bill, there was a big concern that there was, once the drug was given or that the patient had taken their own drug, the doctor couldn't intervene at all. So if something went wrong, say for that person it wasn't enough and they're lying on the floor and they're vomiting and they're, gasping for air, in a normal situation, if that happened in a hospital to a patient, they would be able to get care. But the bill was sort of outlawing the doctor getting involved in any way because then that's kind of turns it into euthanasia. So what happens in Canada if it doesn't work? Is the doctor allowed to finish them off?
It's a good question. I don't know the answer, but I'll tell you that I believe that they're very successful in killing people. So how they've done it, mostly in Canada, by and large, it's intravenous. So that the chances of success with intravenous euthanasia are higher because of the paralytic. So as long as an IV is running, you're probably going to die from it. But I think so, in the U.S., and there's been a little cluster of this, is that prisoners, interestingly, in the U.S. are the only citizens that have a constitutional right to health care. And whether that right is set aside, now perhaps UK citizens have a right to health care too. So what does that mean? If assisted dying is health care in some way, then I think that that to try to write a bill that would say that if there's something wrong, that a forfeiture of a right to health care seems quite extraordinary to me. So there have been executions in the U.S. recently that had to be called off because of an inability to gain intravenous access. There was a notorious one that just occurred in the state of Tennessee of a prisoner named Tony Carruthers, where they attempted to place intravenous's and could not, and then switched to an attempt at something called the central line, where they were going to put an intravenous in his neck. And the physician who was tapped to do this had not performed such a procedure in over a decade and bungled it terribly, used a blade to the neck, and all that happened was a lot of blood. And then after a while, they just gave up. So, could an assisted dying episode fail? I mean, most certainly. So would it be, is this a wrongful life? Like, what would be the claim, and at what point would the right to resuscitation be restored if it was ever truly set aside? There's something quite sinister and even ghoulish to suggest that a bill could write and say that it's like, I've said to prisoners, like, there's something called DNR. I'm not sure if this is a term that's, okay. So I've had prisoners who've told me that they're DNR.
Yes.
And I've told them that you cannot be DNR, because what that means is that if the state doesn't kill you cleanly, that they can allow you to die, because now you said you're DNR. So here is a situation where if the state fails to kill you, can they then just let you die in some horrible sort of way, or should they intervene? Like, death is meant to be like, it's like, imagine the firing squad, okay, which we now have again in the United States. So they finally brought the firing squad back. In the second firing squad execution, apparently the prisoner was shot in the leg and then the shoulder and finally the heart. So imagine a kind of death where, they take a few glancing blows at you that don't quite kill you, and finally you get the lethal blow and you die. So this is possible too. And it's certainly, if the state has said, all we have to do is shoot you in the shoulder or the leg, and eventually you'll bleed to death, and job well done.
Can I just make a couple of comments that I think we need to kind of draw out in the UK context? Because, of course, in the bill as it stands, the method of delivery would be that the patient, the person requesting the death, takes the potion. And it's not foreseen that this will be intravenous because, as you said, Liz, that is more like euthanasia. But the reality is that, of course, not everyone who would be eligible would be able to actually take the potion themselves.
One of the myths of legislation in a country like the UK or like Canada or even in the US, where, there is like in Canada, there's something, there's a constitution called the Charter of Rights and Freedoms. And in Section 7, it's about, I think, life, liberty, and security of the person. But the idea is there that if you make a method of execution available to a particular cohort of people, that what subsequently happens is that more and more people claim that, as a citizen, that they are also entitled to the same service. Okay, so if the members who propose a bill in the UK believe that they can kind of find some discrete example, there's grandmama who's 95 years old, who's lived her life and surrounded by her beautiful family, and everything is done perfectly, and that's what they're imagining. I promise you that there will be more and more people who will then demand the same thing, who will not be that person. And then before you know it, it becomes a problem of people who are lonely and under-resourced or have other kinds of, problems where the medical community has utterly failed them. And now the solution is to just kill them. And if the UK thinks that they can write a bill that will specifically exclude these sorts of people, they are fooling themselves. That will not happen. That will change.
Yeah, I mean, my experience of sort of campaign against this, reading the bill, watching the whole process is I don't think it is possible to write an assisted suicide bill to cross this ethical Rubicon, which is we shall not kill, we shall do no harm, to allow doctors to help people to die. You cannot do that in a way where you're not going to get massive collateral damage. As everything you've said shows that informed consent has gone out of the window because people are not understanding what they're signing up to until the moment that the drugs started. And then maybe they have the most horrific suffering and death, which was the thing they were trying to avoid. Because usually at the point where they take the assisted dying, it's a fear of suffering in the future. It's not usually that they're suffering unbearably at that point.
Yeah.
So we can never know how many cases of unbearable suffering it's actually prevented, because I think a lot of people, it's a fear in their head of something that will never happen, with especially if they get really good at palliative care.
Well, I think that, we have, like, for example, we may ask a patient to compose an advance directive, and the idea being that in some moment of incapacity that they have now articulated in writing their views at the end of their life and how they should be treated. So when I have patients who have those documents, I consider that to be the beginning of a conversation, not the end of it. So those kinds of situations where people seek death, we're asking people really, in a sense, to imagine the unimaginable. And there should always be an opportunity, I think, to change your mind. To once it's there, you may think, now that I'm at the precipice, I'd like to, have the option of saying no or something. And I think that that's the way medical. Now, sometimes in the midst of something, it's very difficult, to make it stop. But we certainly want to provide options for people, I think, to change their mind as it's unfolding.
It's becoming so that the best way to stay in touch with the UK Medical Freedom Alliance is via our Substack, which you will find at substack.com/@UKMFA1. That's substack.com/@UKMFA1, where you'll find our articles and videos published. You could subscribe and be one of the first to get our very important content.
I don't know what has changed culturally, because I was talking to David Jones this morning. David Jones is a bioethicist, and he's just written a paper with David Payton, who you may know. And that looks at the reasons people give for seeking assisted death. And it's quite recent. I think they published it late last year. And it looks at Oregon as one of the countries. And it shows that since it has been introduced, from citing pain as the reason was around 15%, whereas burden was a lot higher, or feeling that you are a burden. And now it's leapt up to 42%. So it seems that I don't know what's changing culturally, but it seems that there is more fear of death and pain. And is this, why do you think that might be, Joel?
I mean, I don't know, branding, I mean, I think that again, as an intensive care physician, I encounter, death on a weekly basis, and in my capacity as a physician, I can utilize medications, that can greatly reduce the suffering that a person has as they die. And we commonly use opioids, the drugs of that class. But I think it was Aquinas who spoke of something called the doctrine of the double effect. And in this, what this states is that when it's the distinction between what you intend and what you foresee. So my intention ethically is to reduce suffering. And I'm going to use an opioid to do it. Now, I recognize that opioids have another property apart from the relief of pain, and that they can suppress what's called the respiratory drive. And so it's possible that when an opioid is used to assist in the pain of dying, that it may shorten a life, if because respiratory drive might be impaired. Aquinas would argue that if the intention is to, again, reduce suffering, that you can foresee that there could be this other impact, that as long as one is not driving towards causing death, then it's reasonable, to practice in that way.
Yeah, I just wanted to come back on that, because do you think there's an abuse of that, though, and a dishonesty? I mean, if I look at what's happening in the UK with end-of-life protocol abuse, that is always the argument that they will give, that we were not intending to kill the patient by administering midazolam and morphine together.
How can that be? What? No, as part of assisted
dying?
No,
I'm talking about end-of-life protocol abuse.
Oh, I see. Oh, well,
within so-called palliative care, but that's not real palliative care. I mean, this is like the Liverpool Care Pathway reinvented. So, but there's that get out clause, if you like, that we are not doing this to kill the patient, we are doing it to ease suffering. But it is a little disingenuous when you're pumping up the doses, because the only outcome of that will be death. But the other thing I want to say is that, coming back again to the bill, is of course pain and suffering are not in this bill. It's not even mentioned. The criteria is a 6 months prognosis. It's not pain and it's not suffering.
Yeah, I don't. I'd have to read the language of the bill, but broadly, these why, So in Canada, I'll tell you that what's very peculiar and distressing is that there's actually most of the killing is done by a rather small cohort of people. So I don't know why that is, okay? But your point about, is there something disingenuous in the practitioner? Like, why there should be this kind of enthusiasm to kill, that's shared by a small group of people, is disquieting. And I think that the fact that there is this kind of the easiest pain to bear is someone else's. And when you are in this way, it does take a very kind of steady hand and a very certain kind of disposition to be with people as they die slowly. And I think that's very dignified. I respect that time, and if I can be there with their family, or sometimes there is no one else to be the witness, that is our job. Our job is not to inject something and walk out of the room, and I think that assisted dying, to a certain degree, seems to do that. It doesn't seem to emphasize, that what you're trying to do is to provide comfort for people. And there can be situations, I think the UK also has a very interesting history of the use of the doula in labor. So what we know is that if a doula is present with a woman who is laboring, that her pain requirements are considerably less. That is to say that the chances of her need for an epidural or some other kinds of medication can be reduced because of the human contact. So if you just want to take the pain away, you can put an epidural in them and walk out of the room. But there's a lot else that's going on here with someone who is, facing the end of their life. And there seems to be, and that's what palliative care, of course, is meant to address. So this is not palliative care. This is and unfortunately in Canada, when it began, the palliative care community was aghast at this and rejected this as them. But sadly, and I don't know why, they have become folded into this and now are very much a part of this, which I think is a very sad situation with respect to the practice of palliative care in Canada.
Of course, it's eroded, hasn't it? It has eroded that distinction that we mentioned in the previous episode on palliative care. And just very quickly, Joel, I think it's because they had their funding. They were threatened to remove their funding, and that is the risk, of course, here, because here hospices, will not be able to, and care homes will not be able to opt out.
Yeah.
So.
Yeah, no, that's happened in Canada.
Exactly.
That's right. You're right. That they were, they were basically told to, to get in line, to join, or they would be excluded.
Yeah,
they would lose their funding. Yeah.
Well, look, thanks very much for all your input. And because time is getting on, we're now at 48 minutes, so it's a bit longer than we expected. But just one very last thing, Joel, because I think this is really important, because some of your studies where you looked at the autopsy reports of people that had gone through this dying process, and I think that was one of the things I found most concerning. Could you just very quickly highlight that just for a quick minute?
Yeah. So what happens in execution is that a large, quantities of either midazolam or a drug called etomidate or a drug called pentobarbital, drugs like this are injected. And what happens is that when the drugs are given, I think, in large quantities, that the way that the drug is prepared, like what the drug is cut with, becomes important. So drugs, when they're developed as for injection, they can either be acidic or alkali, depending on the way that they're prepared. And very, very large quantities of these drugs are injected. And now it's not even the drug itself, it's the preparation of the drug that you're injecting, in a sense, either, something like battery acid or bleach into the bloodstream. And these then, this chemical then rushes to the lungs and tears the lungs up from the inside. And fully about maybe 75 to 80% of the time, I'm seeing this pulmonary edema, this frothy blood at post-mortem in people who are executed in the U.S. Now, there are very few autopsies that I've seen of assisted dying because, of course, who would get an autopsy? Mm-hmm. There has been a small cohort of people who've given lungs, and it's been claimed that, well, look, these lungs are fit for transplant. That's not totally, that doesn't give the whole story, because when the lungs are removed from someone who's given them for assisted dying, they're actually kind of resuscitated out of the body before they're implanted in someone. It's called ex vivo. So they have this kind of ex vivo resuscitation where the lungs are kind of cleaned in a way and healed from this injury, and then they're used. Now, I don't know. I don't have all the answers for how that's working or what's going on there, but that's basically it's the fact that it's a chemical itself that has either an acidic or alkali preparation that is probably causing direct tissue damage.
Okay. No, I think that's important for people to realise. Sorry, ladies, I know you've both got your hands up for one thing or
Liz,
another. So, Liz.
Yeah, no, I just wanted to say actually what you said a few minutes ago about that actually dying. What we are offering is a good death with palliative care. That sense that how important a rite of passage this is for us as human beings, a sort of a spiritual experience that we are going to be robbing people of, because you're robbing the person who's dying of something that yes is tough and work, just like birth is, but actually maybe is really important on some whole other level that we don't understand. And the people witnessing that, the people who have true compassion, who step into that suffering and sit alongside them, I think that is something that our culture, which is so medicalized and so sterilized and just wants to get things done and sorted quickly, get rid of this, we're actually losing something from not allowing people to go through that process naturally with support and care and, a level of drugs that stops anything being overwhelming. So, I think that is what my definition of a good death would be, not what they are describing.
Yeah, I don't know. I think these are unknowable. I think that we know that, that the way that we die matters both to people who witness it and I suppose to the person who experiences it. But as you were speaking, Liz, I was thinking that you must be a Buddhist, because that's very Buddhist of you to.
I'm a Christian.
Yeah, but I'm just saying that at least in Buddhism, that kind of idea about the witnessing of suffering and about the experience of suffering and not blocking the experience, at least I know is practiced in Buddhism and of course and other faiths too. But it's just this idea that what we're losing there is there's something that's very distressing about that. Yeah. I agree. Yeah.
Okay, Amanda, one last thing, or are you okay?
Well, yes, I just want to come back on what Liz was saying, because even in the situation we have in the UK now, with that erosion between palliative care, true palliative care, and some of the end-of-life pathways, is that we are robbing families and the dying person of their end days, when they might want to be sharing stuff with their families and talking about, their lives and And that's all taken away because they are hastened to that end. And I just fear that if this is introduced, exactly what you're saying, Liz, it will. How is that going to impact us culturally and socially? I just think it's such a dangerous Rubicon to cross.
Assisted dying, is death loving. It's not life loving. And as a physician, I love life. I'm an advocate for life. I'm not an advocate for death. I have a working relationship with death. I know I have a respect for death, but I don't see it as a part of my, in my toolbox of things that I provide for people. Like I have to accept it eventually, but I'm not an enabler of it. I in no way, we are not partners in that way.
And of course, that is what will happen to the NHS, as we've said before. An institution founded on saving lives and protecting lives will become an institution that is actively complicit in ending lives.
I agree. That's the risk. Yeah.
Well, thank you all very, very much. We've gone over time, but it doesn't matter. It's all very important, so not a problem at all. Amanda, thanks again for your input and all guys in this. Thank you. Liz, thank you so much again for everything you do for UKMFA, of course. And Joel, I can't thank you enough. Thank you for giving up your time.
Sure.
The information is stunning, and everything you've said is very, very useful, especially for someone like me. I can use what you've told us to try and help people see what the reality is. And I think that's what they need to establish.
Okay. Best of luck.
So,
yeah.
Thanks so much. Okay, guys. See you soon. Thanks a lot.
Okay. Bye-bye.
I think this is a great time to remind you that when you get to the end of the video, if you're watching it on YouTube, you will find 2 links to further videos, which I'm sure you will find fascinating. And it's also a great time to remind you to click follow and like and subscribe so you're alerted when our new videos are published.